Good evening, everyone, and thank you again for supporting and agreeing to be a part of this fourth deep dive into the advances in breast cancer. We have been doing this now for 1.5 years. This is the fourth edition, actually, and we have been doing it post ASCO and then post SABC. Yes. So this time, although I understand that there has been very few advances in breast cancer as such, the whole limelight was hogged by pancreatic cancer and the genitourinary. This was has been the ASCO 2026, but there are some fine articles which we have taken up from the ESMO Breast 2026 and the ASCO. And let's start off with we are having today in 2 hours. We are going to have three panel discussion and one lovely talk by Dr. Sendil Rajappa. And we are going to have the panel discussion for 30 minutes each. And there is the chat is open. If some student or some non-faculty cannot put the chat, please give a message to me directly on my mobile, and I'll be able to do rectify the technical glitch, and I'll try to be as smooth as possible. So without much of a delay, thanking all the faculties, I would like to invite first Dr. Randeep Singh from Delhi, Gurugram. If I can mix both of them together. And he's a lovely friend. I know him for quite many years now. And I really want Randeep to start his panel. And we have his four panelists: Chetan from Pune, Saurav from Bhubaneswar, Biswajit, I think he's there or he'll join in a minute, from Pondicherry, and Stalin from Vizag. So Randeep, next 30 minutes, and he'll be doing hormone positive early breast cancer, the redefining the systemic therapy, and discussing Optima and the Lidera trial.
Okay. Thank you, Sahu, and thanks to the organizing team supporting Sahu. Can I just please allow me the screen sharing? Yes, that's there. Okay. So I think all the four panelists are there, and thank you, Sahu, for giving me lovely panelist. I mean, Chetan Boss is my senior, and all others are quite experienced in the field, which makes the job of the moderator both challenging and interesting. These are the two abstracts which I have to present. Let us start with Optima, which actually is quite interesting. So I will just give a brief background and then we start with the discussion. I think we are having Oncotype DX both for node negative and for postmenopausal node positive, MammaPrint mainly for node negative. Prosigna till date is predictive, is till date is prognostic, not predictive. We have EndoPredict, and then we have breast cancer index, which is mainly not for chemotherapy benefit, but for extended adjuvant therapy. This slide actually has been taken from Dr. M.V. Chandrakant's handle and from his Twitter. Beautifully, I think he has summarized that node positive postmenopausal as per the recurrence score, which decides endo versus chemo endo. In premenopausal, most of us and most of the experts and the guidelines says that whatever it is in the premenopausal node positive, we will be going with chemo and endocrine therapy. Whereas in node negative, more than 26, it is very clear, less than 15, it is very clear, in between 15 to 25, we all are dividing as per the age, whether the age and the menopausal status, and more younger the patient is going from 50 to 40, more lower is the, or more the threshold to start chemotherapy gets lowered as the age gets lowered from 50 to 40. And that is what the cutoffs have been for 15 to 20 and 20 to 25 as per the age. And why we think that in a premenopausal node positive, we shall give chemotherapy is because the RX ponder actually showed that on the left hand side are actually node positive patients, and on the right hand side, it is, I'm sorry, the RX ponder is on the left hand side and Mendact is on the right hand side of the slide. And we can absolutely see that the curves are hugging each other in RX ponder in the 1 to 3 lymph nodes, whereas in a premenopausal, there is a 5% absolute difference. And same was shown in Mendact. So with this, so I think we can start with Dr. Chetan. I think there are four panelists and we can take comment from all of them. Chetan, Saurav, since it is, we can start. Chetan is there, Saurav is there, Stalin is there, and Dr. Biswajit is there. All four are there, na?
Yes, sir. All four are there.
So we can start with an alphabetical way and take the comment starting from Dr. Biswajit, then Chetan, and then Saurav, and then Stalin.
Uh,
So do you agree with the algorithm and the concerns, comments with the whatever has been presented in these 2, 3 slides?
Yeah, I think I agree with the algorithm. The most important is less than 50 node positive. Till the Optima trial was there, there was no data to avoid chemotherapy, and they were to get the chemotherapy. So post-menopausal, there is enough data for both node positive as well as for the node negative. And for the pre-menopausal, the node negative data is there. The cutoffs of risk scores are slightly different for each of this area. So the algorithm as such for the oncotype DX, we agree. We also need to remember 1 to 3 nodes and size of I mean up to 4 centimeter is generally recommended for doing the oncotype DX.
And
Mama print, the other I don't generally do
okay.
In our practice. So I have no this thing, but it's a 70 gene signature, and they are able to also establish something in the postmenopausal status. With respect to age, I have already told menopausal status, I said, and nodal positivity. Yeah, I
Fine,
think.
fine, fine. I think, and so Biswajit now, Chetan, Dr. Chetan,
Yeah, I'm joining.
join. Okay, fine.
Yeah, sorry about that. I was in the lift.
No, it's okay. We will, shall we wait or we can take it later
No,
on the
I'm done. I've logged in. Yeah,
Acha, okay,
I'm
yes.
now
Please,
here.
please
Yeah.
go ahead. Chetan sir,
You
you
can
can go
repeat the
ahead.
question, Randeep. I think he's
Acha,
missed your
okay.
question.
Yeah,
Acha, so
I think
This
I
is
missed the
Randeep.
question. Can you?
So Chetan, the question was that I had showed the node positive, node negative data of oncotype. Also that the recurrence scores are different as per the age and menopause status. And then we
Yes.
also know that in node positive premenopausals, we are a bit worried to start only endocrine therapy. So that was the algorithm which was discussed. So in your practice, mostly what are you following in a brief? I mean, we can, Biswajit has given the comments with respect to the previous 3 slides. You can, sir, tell us that what is your practice with respect to the oncotype and mamma print or prosigna, all any three
Yeah,
of them.
I
As of
stick
today, as of
to.
before the ASCO 26.
Yes, so I use only Oncotype DX. I very rarely use Prosigna, and I prefer to use it in the postmenopausal setting, at the most in the perimenopausal setting between 45 and 50, because the data below the age of 45 is very scanty, and less than 35 there's no question, there's no data, so I don't use Oncotype DX in that age group. And though I have been offering it to people with nodes between 1 to 3, but at the back of my mind I'm a little worried that it's probably going to be a high risk score anyways, a higher recurrence score anyways, and that is why I offer it with a lot of trepidation. But yes, given the small numbers for which I offer it, even node positive up to 3 nodes, I do offer it.
Okay. Anything separate from Saurabh and Stalin? Whatever Chetan and Devashish has said, skipping that.
So, sir, basically, this recurrence scores routinely we are not using. Some of the tests we are using, most commonly we would be using the Kinesis rather. That is there
Ah,
for
yes. Okay.
node positive subset of patients also. And also the recurrence scores are not very useful. They were the patients with grade 3 cancers, breast cancers. In those subset of patients, this oncotype and all, they have very limited number of patients. So in a grade 3 patient, probably we would be considering. So as of now, mostly we are deciding on chemotherapy based on clinical factors. If at all we are doing the genomic risk, then we consider the genomic risk, and based on that we plan the chemotherapies.
And for Can-Assist, what is your cutoff for the number of nodes if you want to use it for a node positive?
Sir, up to 3, sir. That
Up to
is
three.
that is
Okay. Stalin?
Same, sir. I agree with the comments by Saurabh. So majority of the times it is a can assist I do. So preferably in the postmenopausal individuals with an node negative and N1 disease, 1 to 3 nodes. Premenopausal node negative fine, but for the node positive disease, even with 1 to 3, so I'm more spectacle in avoiding the chemotherapy. Majority of the times I tend to give at least a limited duration of chemotherapy.
And Stalin, if I can ask you, what is your cutoff for a node negative post-menopausal to order oncotype DX. I mean, the upper cutoff, 1 to 3 nodes. The lower cutoff, what I want to ask, 1.5 centimeter node negative or 2 centimeter. Though I know there is a grade attached to it, there is a key index attached to it. But roughly, I mean, the lower cutoff where you will not order, for example, 1.5, 2 or 2.5.
Majority of the times it is T1, T2 and node negative, sir. So for
No, no,
few
cutoff
cases
of
I
not
have done it
ordering.
for
Cutoff of not ordering
sir.
means like a 1 centimeter, 0.5 centimeter. That is what I'm a node negative, post-menopausal.
So your voice has broken, sir.
Shall I repeat? Now it's fine? Or if there
Yes,
is
sir. Yes, sir. Now
concern-
it's fine, sir. Yes, sir.
Okay, sorry. Yes. I'm saying the cutoff for ordering an oncotype DX, the lower cutoff. I mean, 0.5 centimeter node negative post-menopausal, you will not order. On a centimeter, you will not order.
0.5 centimeters, sir. Above 0.5 centimeters, I usually offer.
Okay, above 0.5. Okay, fine.
Above 0.5. Yes.
I think this was Optima. Why I asked you was this, that it was a large trial, 4,400, though the breast cancer trials are more larger than 10, I mean the 10,000 and others. The trial schema was anyone more than 40 years, and the nodes were till 9, 0 to 9 lymph nodes were allowed. If you are node negative, then the cutoff of a line was actually 3 centimeter. That is what I was, as Stalin was saying, 0.5 centimeter. ER was positive, the cutoff was taken as 10%. So a good amount of enriched ER positives have been taken. The control arm or the standard arm was chemo followed by endocrine therapy, and the other arm, which was the test arm, was divided based on ROR, which is more than 60 was the cutoff taken in Optima. Now high score.
Randeep, can I just,
Yes.
is it 0.5 centimeters? Is this the consensus that the
Oh,
lower
I
limit
will
is
come to that.
0.5?
0.5 is too low. Yes, I
Yeah,
thought I will leave that here, and then
okay.
this actually the slide came for 3 centimeter. That 0.5 is too low to order. I think even in a post-menopausal, I may give a relaxation at least till 2 centimeter to the females.
2 centimeters is what you're
Yes,
looking
at
at.
least, at least. I mean, you may go to 2.5 for my practice.
Yeah.
At till 2 centimeter, I'm comfortable. And then the score of, we all know that I mean, from oncotype, that the score of 4, that is a grade versus size, you have to combine. And if both of them are reaching 4, then they become a clinical high risk. That is the original oncotype when they included the grade and the size, sum of that. And so the test arm was more than 60 chemoendocrine, less than 60 endocrine. The primary endpoint was based on IBCFS, that is ipsilateral breast cancer, the breast cancer free survival, and not IDFS. And the non-inferiority was, so the primary endpoint was non-inferiority based on breast cancer free survival. And the cutoff use was 3% for the upper arm, that is more than 60 ROR, and 3.5% margin for the lower one, which is less than 60. So this was a trial schema. This is the consort where they had taken around 2,000 patients. There have been some dropouts in the, I mean, 2% not allocated, which is fine. There have been failures. So 97% was the allocation. After that also, there have been a 5% drop in the each arm. Per protocol has amounted to 93%. So 7% of the breakout, which is not allocated, or a high score, or a failure, or non-luminals and other histopathologies, or HER2 has come positive. So these have been the reason in both the trials where there have been a dropouts. The primary characteristics, I think the focus is postmenopausal 61, fair enough, premenopausal 38, of course, balanced between the two arms. Less than 3 centimeter tumors, 54%, more than 3, 46%. 18% of the patients are 4 to 9 positive, which is quite a significant number as far to, I mean, bold enough to start the trial or do it for the first time. So we can start with the same alphabetical order. I think Biswajit and then Dr. Chetan. Uh,
Yeah.
very Biswajit, Chetan, everyone. I'm since we have only 30 minutes,
Yeah,
we
we
can
will be.
whatever the one has repeated, the other can omit and give their special comments or just pass it on. Yes, please,
Yeah.
Biswajit.
So, with respect to the study design looks quite okay. The inferiority, the statistical inferiority margin is based on the absolute survival, whereas in Taylor X, it was based on the hazards. So there's slight difference between the way the Taylor X took the non-inferiority margin and the Optima took the non-inferiority margin. 3% seems to be slightly higher to me. And we only have a median follow-up of a very low. Anyway, that is up to the follow-up part, where the median follow-up duration is just 4 years, less than 5 years. And for hormone, it may not be sufficient for a hormone positive breast cancer. The cutoff scores are okay, less than 60, more than 60. And good part is they have taken 40% of premenopausal. But again, remember the age cutoff is 40. Below 40 patients are not there. So that is 40% is a good number in that subset. And they have included hormone with OFS. So this is something
Yes, actually,
different
that
from
was.
the
Sorry,
previous.
I skipped that. Thank you, Biswajit, for pointing out. So that is very important part. That was mandatory. OFS was mandatory.
Yeah. So I
Yes.
think that was a positive thing in this trial when compared to the previous trial. The inclusion and exclusion, I think, relatively was
I think that you
okay,
have told, yes.
and endpoints were okay. Yeah.
Dr. Chetan, sir, anything separate from what Dr. Biswajit has told?
Just one more point, that they have included a fair number of people, almost 18% people who are N2 disease.
Yes,
That
yes.
is that's a little high risk. I believe that these people often require additional therapies and don't do well with hormone therapy. So it was a little gutsy decision on their part to include N2 disease. But well, that has been their trial design, so we cannot really say much about it. Rest everything, I think Dr. Bishwajit has already covered.
Okay. Anything, Stalin and
Same, sir. I agree with the comments of Chetan, sir. So for 20%, almost one-fifth of the population being N2 disease, it's a very bold decision. But even the whatever may be the results, so in our practice and the scenario, we may not be that bold enough to emit chemotherapy for a patient who is N2 disease.
Saurabh, anything separate?
No, sir, I think what all of them have
Well
said.
covered.
So I would just say this was very much a pragmatic study. Question being asked, can these high-risk patients, can we omit chemotherapy? Very, very pertinent question.
Okay. So let's see the results. And so the first primary endpoint, which was the breast cancer-free survival, I mean, both in premenopausal and postmenopausal, there was a 1.3% observed difference. Hazard ratio was 1.04, and the confidence intervals have been 0.6 to 1.8. I think in the slide I have, yes. So this was so that it was definitely less than 3% as per the statistics. Also, the hazard ratio, which Biswajit was commenting, in the original, in the discussant, they have written the non-inferiority limit also. Per protocol, it was less than 1.39, and that the confidence interval is actually till 1.25. And this was per protocol, and for ROR less than 60, the non-inferiority limit was 1.7. And again, the confidence intervals are actually quite below that. So non-inferiority as per the statistics and as per the presentation and the discussant is actually met. What was more striking was the involved nodes. We don't have the breakup that in these 4 to 9 involved nodes, how many were pre and post menopausal. I presume most of them will be post menopausal, though that breakup is not available to us. But what was surprising that the the hazard ratio is actually similar, 1.11, 1.12, or 1.2, 1.1, though the confidence intervals are very wide. So a lot of events are happening, 0.62 to 2.29. So if you go by, though we don't know the limit here, but the percentage difference, if we see, is around 2%, again less than 3% as per the non-inferiority limit. The confidence interval limit, I am not aware that what was the upper confidence interval in the hazard ratio for this trial data set of 4 to 9 involved nodes. This is the subdivision overall 1.06, PN1, PN2, which we have already seen 1.1, 1.2, grade 3, the hazard ratio is 0.78 with 0.4 to 1.5. Premenopausal, postmenopausal, also we have seen 1.04, 1.14. So these are the results. Before we take the comments and discussion, these are the premenopausal node positive, and in Taylor-X, as we know, the chemo benefit is 5 to 6%, similar in Mendact. And in R-Responder, this was the node positive, where the chemo benefit is there around 5%. And in Optima, the benefit has come to 1.3%. So wherever we talk about younger females with the low genomic skill, especially premenopausals, the chemo benefit has been constant in Taylor-X, Mendact, and R-Responder, irrespective of the nodes. And though we all know that age less than 40, so let's say 40 to 50 for this slide. 40 to 50 for this slide is there, but what happened in Optima? That suddenly the difference has been 1.3 and constant with the around a good 40% of premenopausal females and a 20% of heavy node positivity. So we can start in the opposite way. Always Biswajit has been taking the things. I think we'll start opposite and we can start with the Stalin, then Saurav, and then Chetan sir, and then Biswajit. The comments and the discussions. I mean,
Sir, in this
the questions are
study,
the results are differing.
yeah,
Till what?
possibly we know that in hormone positive, so majority of the chemotherapy benefit is because of the ovarian suppression too. So in this trial, because majority of the population has received the ovarian function suppression, that may be the reason. So the benefit was like this. That might be the one of the reason I'm guessing.
So basically, I mean, I also feel that if in the Taylor-X Act everyone was having a mandatory
Ovarian function suppression.
suppression, maybe this benefit of that 4% would have disappeared, and that makes a very strong point of using Optima in a node positive also, which Dr. Chetan was worried, and many of us are worried of using 4 to 9 nodes. Okay, this I think Stalin and Saurav gave the comment. Stalin?
I gave, sir.
Sorry, Saurav. Sorry.
So, sir, you are very right in saying, so what we always thought was that yes, chemo is probably very important when we have a clinical high risk. And here we see that even if the high risk clinical there, almost 60% are genomic low risk. And here the genomic low risk patients with hormone receptor positivity, predominantly ovarian function suppression is what has brought about the change in the results. And we now, therefore, and we know in the previous trials, hardly 10%, 20%, we do not have the exact data, how many patients in all those trials actually underwent ovarian suppression. So that is why this study stands apart compared to all the other studies.
Okay, Chetan sir. So I will ask you difficult questions since you are senior among all of us. Till what level you are ready to omit chemotherapy after the Optima result in pre and post menopausal?
Okay, so in the premenopausal woman, earlier I was
You are
offering
using
chemo to all
Prosigna.
node positive. Yeah, I was offering chemo to all node positive women, but probably up to 3 nodes with a low recurrence score, I may think of not offering them chemotherapy in a premenopausal women. In a
And these patients,
postmenopausal lady,
sorry, please
sorry,
go ahead. And post menopausal?
postmenopausal, well, uh, uh, up to 3, anyway, we were offering them oncotype DX or not offering chemotherapy based on recurrence scores. But 5, 7, 9 is a little difficult because they have included a whole chunk of between 4 to 9, and 3 or 4 is a very arbitrary cutoff. But yes, I would probably look at other factors like grade. If it's a small tumor, as we often get very early T1, T2 tumors with more than 4 or more than 4 nodes. There, I would probably, and if the lady has comorbidities, age is more than 70, I would probably hold back chemotherapy. But if somebody has a T3, T4 tumor, N2 disease, grade 2, grade 3 tumor, reasonably young lady in her 50s, fit lady, I would probably still consider some form of chemotherapy. But I may tone down my chemotherapy. I won't insist on the full course of 8 courses, or probably I will tone down my chemotherapy based on the genomic score.
Viswajit,
Yeah,
I think
I have
I feel
some different question on the statistics. Can I just point out on the hazards? Because you just told that the upper limit of the confidence intervals cutoff is
non-inferiority.
not there. That is
Yes.
because the way they have taken the non-inferiority margin is different here. The non-inferiority margin is on the absolute survival. That is the 3% on the absolute survival. Whereas if you take the Taylor-X study, it was on the margins of the hazards, which was 1.3. So as you rightly pointed out, if you see the confidence interval, I mean, we are not doing a cross, a cross trial comparison, but if you look at all the confidence intervals, they are very wide. If you take higher as 1.3, even as a non-inferiority margin, then also many of this seems to be very higher when compared to the Taylor-X. And if you see the 9-year Taylor-X, the DFS difference is actually less than 1% at 9 years. And we at 4.5 years of follow-up, we are already having some places, we are having a difference of almost 2%. So are we ready to accept a 2% non-inferiority, absolute non-inferiority at 4 years? I think that's something which we need to keep in mind when we decide to
Okay, point well
interpret this
taken.
data.
I think mainly for the node positive, but I think I will have to skip the discussion part. We have already taken the comments and skip to the next since only 10 minutes or 7 minutes are left.
Can you answer one simple
Yes,
question? Because most of the
actually,
questions
Sahu.
have come for two things,
Yes,
Randeep. Uh,
yes.
that can we do can assist and extrapolate the results into what we are getting it, or is just can assist a prognostic rather than predictive? Do you have enough data to tell that paisa nahi hai, can assist karo and then don't give chemo? So very simple. That's the most common question that's coming in. And Amish has spoken. Number two, is the follow-up that mature enough, or do you want that 9 year 10 years follow-up to be there before we adopt this?
So can assist can be used, but extrapolating, I will rather put it opposite that if I have to use it in a more than three node positive, I will not even extrapolate oncotype also to Prosigna because what has been used and Prosigna is available to us. So can assist has actually a less body of evidence as compared to can assist. So even if oncotype I have to use it in a heavy node positive, I will use it in a pinch of salt. Second is that in a pre-menopausal, I will not cross the limit of nodes, as Dr. Chetan said, more than three nodes, and what Biswaji said, that having a 2% difference, 2.5% difference, it may widen over the years as the follow-up increases. I will not extend as of now for a pre-menopausal more than three nodes. That was second. And third is my comment, which I wanted to give later. I will give it here. Whatever we are seeing is seeing only OFS plus hormone, Sahu. If we add CDK plus OFS plus hormone, I think the concern which we all are having will actually go away. And most of us, when we omit chemo, maybe we do that in a node positive, especially four node positive. If we add CDK plus hormone and omit chemo, I think we will be there. But that answer is not being given by Optima. I hope that answers. I had taken that question in the interest of time so that we can discuss something about Ledera. How that's okay?
Yeah, sure. Please go ahead to the
Okay.
next one.
Oh, fine. So I think Ledera was, I will straight away go to the trial design. I mean, a simple trial design, stage 1 to stage 3. The only difference where this trial design is making that the size was taken as more than 1 centimeter. They have reduced the cutoff further. I think we started from Monarchy where there was only majorly node positive. Then we went to Ribocyclib Natali where 2 centimeter was the cutoff. Here, a grade 3, Chi67 more than 20% and a high genomic scale more than 1 centimeter, node negative, has also been taken in Ledera. And on the other, the pre-postmenopausal stratification was as per the risk stratification, which was defined by Ledera. And the standard arm has been actually ovarian suppression in premenopausal or tamoxifen and anastrozole, letrozole, and not CDK because when the trial started, CDK was not approved. And the second is our oral SERT, giredestrant, which is the oral novel SERT used and approved in the metastatic settings. So this is the trial design. The primary endpoint is IDFS here. The risk stratification was actually more than 1 centimeter, which I have already specified, a node negative. And if you are node positive for N1, the low risk biological features like grade 1 to Chi67 less than 20% and tumor less than 5 centimeter were allowed if you are node positive. N2, N3, there was no other conditional criteria of N2, N3 exclusion. The high risk N1 high risk was with all these high biological proliferation features and genomic assays, and T4 N0. So this was their medium and high risk. I think Natalie Monarchy we can skip to the audience as well as to the experts. They are aware of this. The baseline demographics, it was a pan. I mean the Asian, Africans, everyone was included. 41% were premenopausal, 60% were postmenopausal, 31% were N2, N3, and 70% of the patients were N0 and N1. Previous chemotherapy was 81% in Ledera. So it's quite a risk. I mean, it's not a very, very low risk type of a patients. We can start again with Stalin and Saurabh. We can take only comments from Stalin and Saurabh. Study design, inclusion and exclusion and endpoints.
They seem fine to me, sir.
Okay.
But for
Yes,
as you told that even 1 centimeter low risk population
yes.
may not be an ideal to include, except for the rest all study design seems okay.
Okay.
And sir, here also they
Saurabh,
have
any comments
That
about
seems.
the study
yes, sir.
design, inclusion, exclusion?
Yes, sir. Here also good thing is that they have incorporated ovarian function suppression routinely in all the premenopausal patients.
Okay, so no major flag from the inclusion, exclusion, and the study design criteria. Saurabh, you are on mute.
Yes, sir. Yes, sir. No specifics. So
Okay, so this was the endpoint IDFS, and that was what was presented, I think, in SABCS. This is though the slides are of ASCO, but this was the SABCS presentation. This was gradient versus TAM versus RAI and tamoxifens. The hazard ratio was 0.70, and the confidence interval was 0.57 to 0.87. And lidERA actually showed a significant and clinical meaningful benefit. The absolute advantage of around, I think, 2.8%, that is 92 versus 89%. The OS, the events we all know are not mature. And the safety data, I will just show you the safety data. We can skip lidERA. Safety wise, I think the great toxicities which we are majorly bothered as a medical oncologist and as the females which they take this drug for years has been arthralgia, myalgias, and body ache. So that is quite fine. That the grade 3, 4 toxicities, that is the left hand side table, is not more than 2%. And similar was in standard of care endocrine therapy arm. Also, what was of significance difference was the discontinuation, that when we talk about giredestrant versus other endocrine therapies, the discontinuation rates are very low, not more than 2%. Whereas when we talk about tamoxifen, letrozole, and other drugs, the discontinuation is going to around double, four, that is 4%. And similarly, this was also shown that though grade wise there is not much difference in arthralgia, myalgia, but when we come about stopping the drug, then there is a big difference between giredestrant and the standard of care therapy arms, as highlighted in the red squares, regarding the discontinuation due to myalgias, arthralgias, and bony pains. When we compare this with ribociclib, sorry, I had just rushed it because I think we have not more than 5 minutes, but we will take the pertinent questions from the discussant points from the experts. The discontinuation in the ribo arm has been 16%. Pre or postmenopausal has been around 16 to 20%. And the discontinuation when we use our other standard arms such as abemaciclib, which is highlighted here, is around 19 to 20%. So we can start with Dr. Chetan and then Dr. Biswajit. The trial results, tolerability, and where do we fit this lidERA in the current algorithm, though we know that the follow-up is, I think, 3 years. Yes, 3 years, 2.8 years precisely. And but I think we also have our experiences in the last 5 years of following Natalie and Monarchy from 3 years to 5 years and further. Dr. Chetan and then Dr. Biswajit.
So the tolerability looks good. The discontinuation rates are very few. And I know we are not supposed to do a cross trial comparison, but if you look at the progression free survival with giredestrant alone, keeping in mind that the standard of care arm did not have CDK4/6. If you look at the arms of Monarchy and Natalie, even there the PFS is around 90-92%. So giredestrant alone is managing the same thing which we were able to manage with which we have been achieved with Natalie and Monarchy, and with the 16 or 19% discontinuation rate. So it looks like a good molecule.
Maybe the discontinuation rate has also compensated a bit, Dr. Chetan. I feel that
Yes,
only 2% discontinuation,
only
and the
2%.
compliance.
Yes,
The compliance also matters, the regular drug delivery. Dr.
absolutely.
Biswajit, your comments. And
Yeah.
Sahu, how much minute? I think I have only 4-5 minutes or not even that. Dr. Sahu?
You have 3 minutes.
Okay, fine, fine.
4 minutes.
I'll wind up. I will
Yeah,
wind
they
up
take the floor.
3, maximum 5 minutes, maybe 3 or plus 2. Okay.
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 So
Dr.
the
Biswajit?
yeah,
Yes.
so for the first comment is that it's the first adjuvant study for SERD, so that's something good. My look is that we are looking at standard of care hormone therapy, so I'm not sure how we are trying to compare it with the CDK inhibitor. So they are just looking at whether it is better than tamoxifen or better than aromatase inhibitors.
I think we lost Biswajit.
Yeah, he is frozen.
He's frozen, I think. So my audio is fine. I think we can, till he comes back or he becomes unfrozen, we can go ahead. And he was actually at that. Biswajit has come
Yeah,
back.
sorry.
Yes, Biswajit,
Yeah.
continue. You were frozen.
Yeah.
Yes,
I'm
please go
sorry.
ahead.
So what I was trying to say is that we cannot compare this with the CDK inhibitors. The study they are trying to look at is with the standard only the hormone basal hormone therapy, which is letrozole or tamoxifen. So definitely this molecule looks to be better than that. Whether this molecule can be combined with a CDK inhibitor, that is still unknown. I don't know whether any study is there looking at combining in phase 1 study, looking at combining this with then CDK inhibitor. But with the current situation where we are using a CDK inhibitor with an basal hormone therapy, where we are already getting survival benefit of 4%, 5% in Monarch trial, and 3%, 4% even in ribociclib study. So this is not immediate change. Clinically, we are going to change our practice. So this has to wait unless we combine it with the CDK inhibitor.
So the
Fair
good
enough.
thing
So there is a
about this
study
study
called
is that
lidERA breast cancer. Sorry, I will just, so there is a study
yes,
called
yes, yes,
lidERA
sir.
breast cancer
Yes.
sub-study where abemaciclib will be combined with giredestrant. That is there as part of the presentation. Saurabh, go ahead.
Yes, sir. So the good thing about is that of all the studies, this is the drug probably which is best tolerated. So that is what I found about.
Yeah, correct.
So at least someone who is on TAM letrozole alone, so very few patients are there as there is stratification is going on. At least giredestrant will be better than that. This was the last discussion point. We can take comments from all of you in just 30 seconds. This was what I was thinking, how it will fit in the future. Suppose we don't know how the giredestrant plus CDK4/6 will be there, but as of today, I think Biswajit, we agree this is not practice changing. But where does the future goes? That can be just your comments that where these oral SERDs in the adjuvant setting will come in and they will be with CDK, without CDK, and where you would think that the future will go for them. So as of now, the point is well taken by all four of the experts as well as me that this is not practice changing study. So Biswajit and then Dr. Chetan. I
Yeah,
think we can take yes,
agreed that
very
unless
briefly.
it works with the CDK inhibitor, I don't think this is going to change or the way we are practicing, at least for the high risk. Maybe for the low risk also, anyway, the benefit is not much. It's only just in the low risk, when overall it is just 2.8%, so the low risk patients will be much lower. So unless it works with the CDK inhibitor, I don't see this going forward.
Okay. Dr. Chetan, a very brief comment about this slide. Where do you feel they will fit in or they will come in the low risk, high risk, or they will replace the current strategy of ET plus CDK4/6?
As of now, I don't see any scope of it replacing the CDK4/6, especially in the high risk population. But the one which you have mentioned, very small population which is not eligible for CDK4/6 for whatever reasons, maybe there you can offer SERD. Again, a very small population, maybe with baseline ESR1 mutation, though we don't test it. Maybe for that population, we can preferentially use it an oral SERD. And another thing is the discontinuation rate. Even with aromatase inhibitors and tamoxifen, the discontinuation rate, even in the large trials like Big 98 and ATAC, have been fairly high. In fact, over a longer period, 5 years, it has gone more than 20%. If this drug continues to have a good compliance with a discontinuation rate of less than 5%, maybe later on it may have the potential to replace the standard endocrine therapy.
So I think I will just give my comments very brief. I think Optima is practice changing. Where does Optima fits in is that it gives us a slightly more comfort in a slightly higher risk population of discussing genomic assays, whether it is oncotype, can assist or both. And we may have our boundaries a bit more relaxed, especially when we are putting the patients on ovarian suppression plus hormone therapy plus CDK in a very brief. Oral SERDs, I think they are here to stay with the good tolerability, at least of giredestrant and many others like immunostrength and others are coming in, and maybe the role of ctDNAs, the role of ESR1 mutations in the adjuvant settings. I think it will take a 5 years for us to reach, and when they fit it into the algorithm. But as of now, someone who is intolerable to TAM letrozole, and we all have such females who are really bothered and crying coming into the OPD, I think there it will definitely fit in. Thank you, and
No,
thank you,
thank you,
Dr. Sahu,
Randeep.
for
I
giving me two,
think
3 minutes time.
Amish echoed my thought that there is a patient group who are not fit for a CDK4/6. And Vishwajit, I totally agree that for the larger concept of lidERA to be accepted, it will have to face a randomized comparison to a CDK4/6 to endocrine. But there is a patient who are not eligible and not tried in the CDK4/6 adjuvant. Probably this looks a very good alternative, but I think we need a 5 to 10 years follow-up. 3 years is too short for a hormone positive cancers to change practice. But tolerability is excellent. That has been proven.
But
So
there has
thank you
been
all the
another
panelists.
another trial of Ember 4 where after 2 years the randomization has happened, sir. So if at all need to practice CDK4/6 with standard endocrine therapy, after that, if at all that trial comes positive, so you can change it to the oral side after 2 years, the Ember 4 trial.
Let's hope so. So point is, we'll move on. We have taken 5 minutes more for this, so I will call in Dr. Amish, and we can have the chat is active. So please do contribute in the chat, Randeep and all the other panelists. There are quite some questions. Randeep, please try to answer those, so that people do feel that their chats are being respected. So
Sure.
I will call in Dr. Amish. Who is going to moderate? We'd had the systemic therapy. Now we are going to just change gears to revisiting local regional treatment in early breast cancer. So he'll be discussing the Senomac trial. Can we omit surgery at all? The surgeons won't be very happy for that. And if the time permits, we will talk about should we be just dissecting the axilla, because we medical oncologists want to give more of adjuvant CDK4/6. Amish, all yours.
Thank you.
You can invite your panelists, please.
Is my screen visible?
Yeah, it is visible. Should I invite the panelist?
I will. Dr. Vedant Kabra.
Yeah.
Do we have Vedant?
Yeah, Amish, I'm here.
Okay. Dr. Kinjal.
Yes, good evening, sir.
Good evening, Dr. Ashish.
Hi.
Hi. And Dr. Soumya.
Yeah, good evening, sir.
Okay. For if there is any glitch on my side, on the technical side, please take over. My PPT is there with the organizers.
I object to my name written wrongly. It is double O. So I totally object, and you have to give me coffee next time we meet.
मैं हमेशा ऐसे HU ही लिखता हूँ. तुम अपना नाम चेक करो whether वो double O है या U है.
चलिए, please carry on.
Okay. So
So
the
8:45, Amish boss, 8:45. Yeah.
Yeah, absolutely. You
Yeah.
tell me when 5 minutes are remaining, but
Yeah,
I
yeah,
have
sure.
watch with me.
Sure.
So first paper, what we are discussing is omission of completion axillary dissection in patients with breast cancer and sentinel lymph node macrometastasis. And this is, you have to have overall survival and patient-reported arm morbidity from the randomized Synomic trial. After a long time, I'm reading this on the screen, and there is a reason for that. So we will come to the next slide, and this is NCCN guidelines downloaded today morning, third version of 2026. Vedant, you can see this?
Yeah.
Okay. So this is my first bullet point, that sentinel lymph node mapping and excision onwards. Not identified, you go for ALND negative, no further, positive, and all the criterias, 4 criterias have to met before you omit axillary lymph node dissection. This is today's standard of care. Is that okay with you, Vedant?
So not entirely.
Okay. So please tell me.
Yeah. So you see, this is not the first trial for macrometastatic disease.
No,
on
we have not come to
sentinel-
the trial as yet. I'm talking of
Okay.
before trial, the standard of care, which is written in NCCN guideline today morning.
Okay. So I don't agree with certain things like T3 disease, T3 tumor. Although I know
Okay.
that our trial today includes
Perfect.
T3, but I will talk about it later when you discuss the trial.
Okay.
I for one have changed. I know in India we were very late to change, and we were skeptical because most of the trials on the basis of which this recommendation has been given had a median tumor size of 1.5 centimeter. And we hardly ever see that kind of tumor size. But a good number of surgeons are now changing. We are okay omitting if there is one macrometastatic disease and we have removed, say, 3 nodes. If there are 2 macrometastatic nodes, I have removed 4 or 5 nodes, I'm okay. But if I remove one sentinel node that has macrometastatic disease, I'm not okay.
Okay.
Micrometastatic, I'm okay. Extranodal extension in that node, I'm still not okay. So there are certain things which I would agree with and I'm following.
and there are certain where I would not
You
agree.
agree.
Yes.
And if patient has preoperative chemotherapy and N plus remains clinically positive, yes, ALND. If N plus gets converted to clinically node negative, you go for sentinel lymph node, because this is one of the biggest area where we all deal today.
Yeah. So this is something clinically N0 remaining N0, we offers SLNB, but N
Correct.
plus turning to N0, we are still not offering SLNB, to
Still
be
not
honest.
offering.
To be
Okay.
honest, we are not. I
Okay.
think there is now good data that we should start offering them, provided we are able to remove 3 sentinel nodes at least. In that case, we have a good sensitivity. And
Perfect.
we use double tracer.
Double tracer and at least 3 sentinel lymph nodes, only then you are comfortable. Otherwise, a front node positive, you are still preferring ALND. I get it.
I think most of us in India are preferring, or almost all of us. Almost all of
Okay.
us.
Dr. Kinjal,
Yes, sir.
we have so many enthusiastic radiation oncologists in India. Do you ever earlier have replaced axillary dissection with RT in your practice?
So,
See, surgeon has decided it's only sentinel lymph node, and there are 2 macrometastases. ALND for some reason was not done. And have you replaced before today?
so when Ambrose came into picture, that
Here
time
is the
we had a
Ambrose.
discussion. We had a discussion with our surgical team. My surgeon is the president of ABS, Dr. DG Vijay. So we had a discussion, but we have never practiced. So we have not shifted from axillary lymph node dissection to just going for RT. And if there are 2 macromats, usually the completion axillary dissection is done. But one thing which you asked Dr. Vedant was about the SLNB if after chemo, if it is negative. So that has started practicing at our place. If post chemotherapy, they do 3 lymph nodes SLNB, and if they are negative, they don't go for a complete axillary resection, because if they have responded well to chemotherapy. Yeah.
Perfect. I
So,
think this is
let me just put a caveat here. Right
yes,
now,
Vedant.
whoever is doing it is largely doing it for N1 disease,
And
not for N2 disease. Am I
Not
right,
for
Dr. Jani?
yes.
Yep.
Perfect. I think point very well taken. So today's trial, what we are discussing, started and it was first published in 2024. And in 2026, ASCO, the readout for 5 years happened, and that is what we are discussing. So this is the Cenomic trial, a randomized non-inferiority trial. Primary endpoint is overall survival with the non-inferiority margin of 2.5%, and the upper limit of HR is less than 1.44. Target accrual 3,000 patient. In fact, it is, to be precise, 3,250 patients, where 190 events were required for statistical power. Again, sentinel lymph node biopsy up to 1 to 2 macrometastasis. I randomized into completion ALND or omission of ALND. Rest of the treatment remains the standard. Dr. Ashish and Dr. Soumya, when you talk of non-inferiority trials, very quickly in 2-3 minutes, do you look at these points, whether these are powered, whether non-inferiority margin really makes a sense in clinical setting? What are the subgroup sizes where it is there, and the confidence interval? In fact, Randeep touched upon that confidence interval in the Optima trial. So both the medical oncologists, Dr. Ashish and Dr. Soumya, quickly.
Yeah, I mean, of course, I think a lot of investigators, in order to reduce the sample size, they go with a bigger confidence interval or more acceptable difference. So in your previous slide, if you can just go back, what was the calculation they used here? So we have, as a clinician, we have to just I mean, figure it out for ourselves that basically, are we comfortable with the point estimate falling anywhere in that range based on what the trial shows. Yeah.
Perfect.
So from my side, so the non-inferiority margin, if we look at that, that is a very important part. And the power of the study here was 80%. That means the ability to detect the non-inferiority part was true. Non-inferiority was 80%. The problem is that the upper confidence interval, the upper part was 1.44. That is because they had assumed that the axillary lymph node, if they don't do, then that will drop by 2.5%. So somebody who is doing that 94% comes down to 92.5%. So based on that, they had calculated the non-inferiority margin was kept at 2.5%, and the confidence interval of 1.44 does look very high. But if we look at that, the calculation part, it was not arbitrary, it was calculated.
Absolutely. So my idea of bringing this slide was that non-inferiority margin in this trial, basically it's a clinical sense what the authors decide. It is not based on an absolute science. Power, you need the sample size for it to be powered properly. Subgroup sizes and confidence interval are good to have. So as a concept, Soumya, when you read this article, does the first thing come in your mind, oh shit, we are going to miss on the eligibility of adjuvant CDK4/6? मेरे को 2 lymph node से ज़्यादा मिलेगा नहीं, मैं क्या करूँगा? How will I see, especially abemaciclib, I'll miss out on many patients. Does it come in your mind?
Yeah, I agree to that part. So suppose say the axillary lymph node dissection we are not doing, probably something like around 15% at least will come down. So somebody who
15% will
does
come
the
down.
axillary lymph node, then the extra 15% will be picked up, and so we might be missing on that part.
Vedant, assuming you have designed this trial, quickly, the only point is, are you worried about that we medical oncologists will miss out on adjuvant eligibility?
How many patients actually would be eligible for CDK4/6 if you complete the LND and you find 4 and more nodes,
So
right?
we'll come to that. We'll come to
We have
that.
to see
But
that. So
are
it's
you
not a very
worried?
high
My point
percentage.
is, are you worried or not?
You're worried, yes.
Yes,
Not-
I'm concerned.
not-
Whether it makes an impact, that's a different discussion.
Not
Amish,
so
can I
much,
interrupt you,
because I
Yes,
think
Ashish. Yes, Ashish.
our threshold to give CDK4/6 has come down after the NAT. So
Chetan said hardly there'll be anybody who won't get CDK4/6.
Who won't get it?
So I
Actually,
was wondering
there
that,
are
how many CDK4/6?
there are so many other criteria apart from nodes, and most of them fulfill one of them.
We
Amish,
will this is since both Ribo and Abima are FDA approved. I will not go into the details.
Amish,
The
can you hear
same
me?
thing. Yes, Senthil, please.
I just did some literature search because I had to do another study, not another study, sorry, another talk. So let me read out some numbers. I'll just take 10 seconds.
Yeah.
For one overall survival event to be prevented, that means to save one life, you have to do between 123 to 345 sentinel lymph nodes, 106 to 807 complete axillary lymph node dissections, which are unnecessary surgeries, which will result in 89 lymphedema cases, resulting in up to 270 or more grade 3 or more toxicities with CDK4/6 inhibitors. And in the US, this will cost $23.1 million.
Excellent. Just to add on to that, my last slide was on this only, Senthil.
This is based on 19,000 patients
if
that
you
they
take
have looked
overall
at.
survival, you have to dissect 807 axillars to save one life.
Correct.
That was going to be my last slide, but that is something which is very interesting. Soumya, we'll just move on. Sorry.
Sorry, I interrupted. Sorry.
No, absolutely, Senthil. You are always a pleasure when we hear something from you. Don't worry about that. 87% of patients were hormone positive in this particular trial. Soumya and then Ashish, quickly, yes or no? Would you believe this data for triple negative and HER2 positive?
So for triple negative and HER2 positive sentinel lymph node, yes. Omitting axillary node dissection, no. So
no.
I think
Okay, Ashish, you agree with Soumya?
I think for most of the other TNBC and HER2 positive, we are anyway moved to neoadjuvant therapy. So I'm not sure if I'll apply the results of this study in
all of
something
us
with
agree
post
that
yeah.
these results are not to be applied on TNBC and HER2 positive till we get further things. Background, I will skip. Eligibility, we said T1 to T3 they had taken and 1 to 2 sentinel lymph node with macrometastasis. T3 means more than 5 centimeters. Now we have discussed this earlier. How many of us are comfortable to include this? We have to see that in our thing. But there was patient-reported outcome, and they included EORTC, QLQ, C30. I remember Senthil reading out about 89 lymphedemas out of 105. What he said, EORTC, QLQ, B23, and lymph ICF scores, which is there. So this was randomized was 2,766 patient. Ashish, you were there. You are there on my screen. 3,500 patients initially were needed for margin of 2.5% at 5 years for breast cancer specific survival. Uh, do you agree with 2,700 or 3,500? What difference nahi hai? We'll move on.
Yes, sir. I think now most of our early breast cancer trials, the sample size is around 3 to 5,000. So we need that much number.
We need that much number. Perfect. T3 was just 5.8. Mastectomy was 36%. And as we talked, 87% were hormone positive, which was there. One sentinel lymph node, 84.6. Vedant, you are in the comfortable zone. Majority had only one sentinel lymph node. ENE was something addition compared to the previous trial. It was 34.3%. Median lymph nodes were adequately removed, which were there. 2.9% were PN3 again. Now, this is something which is there. Vedant, are you happy that ENE is included and 1/3 of the patient had ENE?
Yeah, I'm happy because this is something which we are not comfortable leaving behind. And
Absolutely.
you see, 84% having only single node positive. So it
You
is
said that you're
yeah,
comfortable in
yeah,
ALND there,
yeah,
and they listened to
yeah,
you.
yeah.
Right, absolutely. So, median follow-up of 60 months, and if you see, there was absolutely not much difference in the survival. The primary endpoint was met, as we will see in the next slide. Now, this is something which is very important. Radiotherapy, and Kinjal comes here. Kinjal, 90% of the patient had radiotherapy, and they had done the audit on radiotherapy, and they found that actually the higher dose, 14% higher dose of radiation, was given to level 1 axilla. You think that took care of the survival? 90% patient receiving RT, no clinical scenario where 90% of our breast cancer patients require RT if they finish ALND. Kinjal, your thoughts on that?
Yeah, so usually when we treat either the chest wall or when we treat the whole breast, level 1 is usually covered in our radiation fields. And to be very honest, at this point of time, we are not very comfortable leaving the ALND and going for radiotherapy and not the ALND. We have still not moved towards that. So we have to take everything with a pinch of salt. Whether you go for radiation for the level 2 and higher, usually we don't go for level 3 lymph nodes, because otherwise again the lymphedema possibility will be equal to surgery. So generally level 1 is treated along with radiotherapy, and the number is like 87.9 versus 89, almost equal, I would say.
No. Both the groups, this is like it's too high a number for adjuvant radiotherapy if you see in these
Majority
particular
of the
patients,
patients would be,
and that's why the audit was done for the radiation dose.
yeah.
And the authors, they did the audit. That is what the paper has written, that an external audit was done on RT, and they found that the RT dose which was given was 14 to 15% higher compared to what was a pre-specified protocol. That's why I asked you this question very quickly. Ashish, in you are working in a resource constrained hospital.
Amish, can I ask Kinjal a very specific question? In a
Yeah.
normal radiotherapy technique, do you cover the axilla? Do you radiate, or it's the chest wall? What you do, and you expect the rays to just take care of the axilla, or do you cover the axilla as such?
No. Generally, we don't cover if axillary lymph node dissection is done.
So coming to that, if you look at it on Amish's slide, around 90% of that, the 90, here. They have covered axilla in around 90%, 88%. So is it that what a read of this trial is, because they have not done the axillary dissection, their radiotherapy is taking care of it, and nearly you would not have given radiotherapy as such to this nodes, and here you're giving it. So do I read it that way?
So that is what my question was to Kinjal, and I think this is the answer which none of us will know unless and until we do a randomized trial. Tarini, I'll move on. This is a 5-year overall survival with 87% of patients HR positive. Ashish and Soumya, would you change your practice at 5 years or you need a longer follow-up? This is a confidence interval variation, what we see in both things, which is there.
So the report of the recurrence-free survival, if you see, is almost 90% in both arms. So the idea here is that, see, if you look at the control arm where they had ILND, about 30 to 35% of them did have additional lymph node. So what we are seeing is that that the surgeon doesn't need to clear the axilla in order to cure the patient from these nodal metastases. I mean, our systemic therapy, endocrine therapy, and radiation therapy can do that. So
Ashish, you believe that? Soumya?
Yeah, in certain subgroups, I am worried, but
Subgroup
otherwise,
you are worried.
yeah.
Okay. This is
So
what you are subgroup and you are worried about the
the
subgroup.
T3, you can see the
So
confidence interval.
Soumya, let me ask, and this is my last question on this trial. We have 10 more minutes to discuss one or two more trials. 87% of HR positive, underpowered, the sample size is small, what was accrued, 90% patient receiving radiotherapy, which is there, and CDK4/6 was something which we have been discussing for last 40 minutes. With 5 years of survival, do you think that this is right now practice changing, or you would wait for 2, 3 more years? A simple yes or no, Soumya.
So mostly yes.
Mostly yes. Ashish, yes or no?
yes, I think this is good. I mean, it definitely reduces the morbidity.
Reduces the morbidity. Kinjal, yes or no?
Yes, I agree.
You agree.
Yeah.
Vedant, yes or no?
I've already answered that partly. And as far as your 5-year survival is concerned, we have another trial with 10-year survival now, Amaros,
Yes.
which also has similar conclusion, almost similar inclusion criteria except T3. So partly
So
yes, and I've
according to you,
already
also practice changing. Tarini and Senthil, just yes or no? I move on to the next. Tarini, yes or no?
Yes, for the
Yes.
select group, not for
For
all.
the select group. Senthil, yes or no?
Yes, for the
Yes,
trial inclusion
inappropriate is
criteria.
answered.
Okay,
Yeah,
perfect. Great. You have already answered. I don't have chat in front of me. Apologies for that. 7 to 8 minutes we have, and this is from the MD Anderson Cancer website. Select breast cancer patient may be able to omit surgery following ablative radiation. This was what they have written, and this was what the trial, which was published in May 2026 in the Radiotherapy and Oncology Journal. The clinical question was that in a select subgroup of patients, can we omit surgery? That was number one point which was there. And who are these patients? This was a phase 2 trial. MD Anderson carried it out. 20 patients was the sample size. All patients had T1 stage, luminal A HR positive, N0 confirmed, oncotype DX has less than or equal to 25, postmenopausal, and willing to take endocrine therapy for more than or equal to 5 years. Now, radiation which was given was delivered. So, first 3 months of hormone, followed by SABR, 1 to 5 sessions, and the dose of radiation was very high. Kinjal, can you discuss on this SABR dose? 5 fractions, 1 fraction. Is it feasible in India?
Yes, sir. It is feasible because the trial which came called Fast Forward, they have started treating patients with 5 fraction of radiotherapy, and it is well accepted in UK. During the COVID time, I think Tata Memorial had started doing patients on Fast Forward only. So they give 5 fractions, around 26 gray in 5 fractions. And sometimes, if it's a BCS case, they boost up the lumpectomy cavity along with that, or maybe is a sequential. So the treatment is finished in 5 sittings only. And for a very early lesion, we have already started moving towards APBI, which is like an accelerated partial breast irradiation. But here, if you are not going for a surgery, this has not started in India as of now. Nobody is practicing avoiding surgery and giving only radiotherapy, ablative radiation plus hormones. That has not started.
So this is the phase 2 data from MD Anderson. Please remember, it is a concept which is there. Now, this concept, what was the concept? That there is no surgery, shorter treatment available in India. It is possible, as you rightly said, in a better quality of life. So out of 20 patients, if we see, there are 12 patients. So what they did was they did the biopsy 3 months after SABR was delivered. And if there was a complete pathological response, no surgery was done. And if there was incomplete pathological response, then surgery was done.
Clinical
And at the
response.
end of 3 years and 5 years, they saw
So
12 out
clinical
of
response
20
or a
patients.
pathological response.
Yeah, 12 out of 20 patients did not require surgery. And at the end of 3 years, nobody recovered. It was 100% it was there. Now, the question which is there, Vedant, these are the few questions which are put here. Are you worried, Vedant, that there is only biopsy done after 3 months and you do not have a complete tumor specimen to prove that there was a pathological response or no?
So I'm worried as a whole because this is very, very
We are still in
small
the
data.
concept. Vedant, practice has
So
not changed. Don't worry about
yeah,
that.
no. I'm coming to it. So now there are studies where post chemo similar biopsies. This is a WAP biopsy which was done in these cases.
Yes, it was WAP
Now,
biopsy.
so there are studies now which are showing post chemo WAP biopsy, not showing any tumor, don't do any surgery, and they have also had very good local control as well as survival. So the time is going to come for that. But in the current time, I'm concerned.
No, as a concept, would you
As a
like to
concept,
carry out this trial in the similar design for say 500 to 1,000 patients?
of course we can and we should if we
And
want
you
to
are you
avoid.
are you are okay with
But you
just a
see,
biopsy
we are
specimen?
talking of less than 2 centimeter tumors, and we are talking of
Correct.
surgical morbidity. We're talking of scarring, and nobody is talking of radiotherapy causing morbidity there. Right? That also causes you have to see the post radiotherapy breast in some patients.
So I asked you the design, Vedant. Are you okay with the
I'm
design, or
okay.
you feel there is too high a dose of radiotherapy?
No, I'm okay with the design.
You are okay with the design. Okay. Ashish, are you okay with the design to
Yeah,
take it to
I think
phase 3?
I think so. There's a lot of selection here. I mean, these patients are good patients. They're very small tumors. Maybe half of them
Yes.
detected, and they're all luminal A's. So, and then also some of these biopsies, what we're talking about, they take out so many cores. I'm sure after end of those biopsies, there's nothing left in that tumor. So, 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 and also we last year also I forget the name, but we saw a trial which was letrozole versus radiation, and they were able to prove radiation alone was good enough. So they basically this is a very indolent tumor, maybe one of these overdiagnosed tumors, and these tumors are and these are older women, so probably. I mean, but we don't know. I mean, it's just like, for example, in prostate cancer, we know where we can wait and watch, where we can treat with radiation. Breast, we still have to figure that out. And I feel a selection will, in the future, the molecular selection will probably guide us. But again, I agree with Dr. Vedant also. I mean, it may be faster and more economical to do a small lumpectomy than an
SABR.
SABR. Yeah.
So, Kinjal, SABR cost in your center is
Around 2.5 lakhs.
2.5 lakhs. Vedant, the cost of BCS lumpectomy in your hospital is?
It's less than that.
Okay, it's less than that. Okay. 3 fractions
Obviously,
versus.
I'm giving the amount which is there in general ward, not in private ward. Private
Okay.
ward would be more than this.
Right. I think in terms of the cost, uh, in a private setup, both are almost similar. In a government setup, it's a different ball game altogether. But surgery scars and surgical morbidity versus long-term radiation morbidity, which is there, Soumya. Would you like to wait for 5 years before you take it to phase 3? Long-term morbidities of radiation, long-term, HR positive may relapse at 4th year and 5th year. Soumya, would you wait for 5 years before we take this to phase 3?
So, sir, the median age of the patient in this trial was 70 years. So
71, yes, to be
yeah, so
precise, correct.
that tells that the patients were very selected patients who wanted to mostly avoid surgery. As a proof of concept, this is very good because SABR we are doing in stage 1 lung also. We have seen that. So as a proof of concept, yes, all the patients underwent a genomics oncotype DX. So oncotype DX itself is 3.5 lakhs. So all the patients have undergone oncotype DX, and according to that, the score was looked at, and only patients who were less than 20 or 25, they were only enrolled in such cases. So I think this as a proof of concept, yes, it is good, but we need larger trials to look at.
So I think everybody agrees that this particular data is something good enough and it's interesting enough for us to take this to the next level. I personally believe I'll wait for 1-2 more years before we take it to next level. My biggest challenge is surgical specimen absence. I would have liked to included a surgical specimen arm, but then the trial itself loses its shin, because I'm little worried about pathological complete response rate, especially in indolent breast cancer, which can be actually cured with simple surgery and followed by adjuvant hormone. But again, almost all the panelists believe that as a proof of concept, this is good. So that is what the conclusion is. Last paper today, which was actually read out by Senthil, and I have 1 minute more, Tarini, I'll finish on time. So this was a pooled analysis of 5 trials: Natali, Monarchy, Senomec, Sound, and Insema. Feasibility of sentinel lymph node biopsy and ribociclib at 5 years, 123 for IDFS, 129 for DDFS, and 807 for overall survival, and the same was for abemaciclib. What this tells me is that you should not be worried as of today for CDK4/6 eligibility to omit axillary lymph node dissection if the patient is right. That is what my conclusion for the trial. Both the trials are there. We have 1 more minute if any of the panelists want to give any suggestion or any talk. Otherwise, we hand over. Yes, Vedant, please.
Amish, you as well as Dr. Senthil both had mentioned about 89 lymphedemas. The denominator that you mentioned was 120. I don't remember what Dr. Senthil had said. I don't agree. 89 patients out of 120 axillary dissections. Nowhere in the world this is such a high rate of lymphedema. Nowhere in the world.
No,
So
Vedant,
all grades included? All grades included, Vedant?
All grades included. Yeah, all grades included.
I agree.
So
Vedant.
I'll tell you, those who have been very, very stringent in measuring it have reported up to 50%, and most of them are milder ones. Those who are little less stringent have reported 25 to 30%, not beyond that.
Correct.
89 out of
Point very
120.
well
No,
taken.
not 89 out of 120. No.
Point very well taken.
Yeah, that's why I said I don't remember the number that you mentioned.
That's right.
I have 1 point
This is for
only.
the total analysis. So they did a little bit of a
Soumya.
complicated calculation. I mean,
So-
there's no
Yeah,
time to
that's
go
fine.
into that.
So
So
actually, this is
89
not
out
the
of
number
807
needed
is
to
okay.
So this is not the number needed to treat. This is number needed to diagnose and treat. If you look at the NNT,
Correct.
it is only 6.
Yes.
Correct.
So
Correct.
NNT to diagnose and treat comes to this big number. So I think there
Absolutely.
is reservations on that.
You're, Soumya, absolutely right. And thank you all the panelists. 45, Tarini, and I close.
Thank you. Thank you, panelists. Thank you, Vedant. Thank you, Amish. Thank you, Soumya. Thank you, everyone, actually, and Kinjal and Ashish. So we move on and come to the thing I think Amish would love to listen now. And this would be the talk by Dr. Sendil. And most of us enjoy and actually have learned a lot of our dissecting the trials from Dr. Sendil actually. And for the next 20 minutes, we will listen him talk on how do I treat hormone positive metastatic breast cancer today in 2026 post CDK4/6 inhibitor. I'm very sure we will not have the financial constrictions. Dr. Sendil.
Can I share my slides, please?
Yeah. Please, Daud, can you just take away your? Yeah.
Okay. All right. Thank you, Sahu. It's always a learning experience when you ask me to speak on an abstract topic like this, because it needs a lot of reading to simplify and give you what people need to take home tonight. I've titled this, How Do I Treat HR Positive, HER2 Negative Advanced Breast Cancer Beyond First Line CDK4/6 Inhibitor in the third quarter of 2026, because the fourth quarter will be ESMO and I don't know what's cooking up for ESMO, and things might change. Life was very easy as long as it was just anatomy that was deciding what you wanted to do. So anatomy and biology were hugging each other, so things were easy. Now, when molecular biology started coming in, beyond just the Ki-67s and so on and so forth and grades, things started getting even more complicated, and I'll show you how things have changed over time. Now, this is what has happened over the many years. Look at the left extreme of your slide. 2015, we had 4 agents in the hormone receptor positive space at that point in time. When you come to 2026, you have 13 targeted agents. So how do you place all of this? Some of these targeted agents you can see on the screen here over the timeline. The lower part of your slide, left extreme, what are you getting with first-line CDK4/6 inhibitors today? A median PFS of around 2 years and an overall survival of around 5 years. In real-world practice, very interestingly, most patients receive only 1 line of endocrine therapy before transitioning to chemotherapy. Now, that's not uncommon in where all of us are working in. Even interesting is that they looked at 63,000 patients in 17 studies. 13 to 66% actually received first-line chemo, despite those patients having hormone receptor positive, HER2 negative disease. Now, that's a huge number. And biomarker testing in this setting in the US, only 1 in 4 or 1 in 5 patients got biomarker testing. Now, that is a dismally low number for a country like US. It happens in our setting. So these are some stark data points that one needs to keep in mind when you start analyzing the rest of the studies and the way these were done. Now, let's start with the biomarkers. What are the standard biomarkers? We look for ESR1, PIK3CA, AKT-P10, somatic BRCA, and of course, the tissue agnostic markers. Germline testing for BRCA and PALB2 to assess eligibility for a PARP inhibitor. We also now love looking for IHC, low HER2 and ultra low HER2. And then there are a set of emerging biomarkers which we routinely are not expected to do in practice. Maybe in the next few years, we will understand this better and start implementing this in practice. Extremely busy slide. Please don't run through it. I will take you through it. Now, first point I want to make here is that endocrine resistance. Now, when somebody progresses on first-line hormone therapy plus CDK4/6, you call it endocrine resistant, obviously. That this is a biological continuum. Now, in the most recently concluded ABC-8, they have rephrased all of these resistance criteria. And I'll show you this one by one, because in future, when trials are being designed, the terminology that they will use in order to categorize patients will be very different. So let's start here. Number 1. First thing you see here is that the term endocrine sensitive is kind of going away completely. The left 2 boxes contain the criteria for what we used to call as endocrine sensitive. That means hormone therapy naive patients. Now, why are these not being called endocrine sensitive? Because we actually don't know whether they're sensitive or resistant. We are assuming that if they are de novo, they will be sensitive. No, they need not necessarily be sensitive. So this is one important point. However, we assume that the likelihood of hormone therapy benefit is going to be quite high. The other category of endocrine sensitive disease is now being called as secondary resistance, that is late acquired. If there's late acquired, then you have a category that is called early acquired, which is what we used to call earlier as secondary resistance. Okay, it's a little confusing. I will not keep repeating this again and again for want of time, but the point is that all of these criteria are getting rephrased and the terminologies are being polished off in order to reflect patient characteristics better. On the right extreme, you have a category that is endocrine insensitive, which means they have very low probability of benefiting from any endocrine therapy. This is becoming like platinum sensitive, platinum resistant disease, 6 months, 3 months, no response, so on and so forth. Now, if you have somebody who's got probable sensitive disease, indolent disease, prolonged PFS on the first line therapy, limited disease burden, these are patients who will be considered for another line of endocrine therapy. While on the other hand, if you have primary resistance, absolutely no response to any endocrine therapy at all, or they've already had multiple lines, if they're rapidly progressing, high tumor burden, then these are patients who should not be taken for a second line of endocrine plus minus targeted therapies, because that is the therapy that you have in this penumbra. Now, why am I calling it this a penumbra? That is the space that has some commonality between characteristics of sensitive disease, resistant disease. So you have to be very careful in choosing your patients for second line therapy based on multiple criteria, both clinical, response to previous lines of therapy, rapidity of progression, and the burden of disease. So you use these criteria to transition from an endocrine therapy to ADC or chemotherapy. So this slide will be available for you to look at as many times as you want. However, the publication will come very soon in 2026. So that will contain all of this. Now, this is an extremely crowded space. The CDK4/6 post space is an extremely crowded space. Now, I would prefer to divide this into two parts. The first is a set of therapies that have biomarkers. That means you look for the biomarker and then use that therapy. Now, what are these? There are three sets here. One is the group that is SOLA1 and the capital of 291, which targeted patients who had a PIK3CA or a PIK3CA AKT-PTEN mutation. These studies were positive for PFS. There are some problems in terms of tolerance with alpelisib. All of us know that capivasertib is a better tolerated drug. Now you see here these numbers, right? You see here that this is 11 months with alpelisib, 7.3. And the reason for capivasertib trial showing a lower median PFS, though the hazard ratio is quite good, is because in the CAPItello study, 70% of them had already had a CDK4/6 inhibitor, while in the SOLAR study with alpelisib, only 6% had had. Now, having a CDK4/6 inhibitor can make a huge dent to the median PFS that you're likely to achieve in the next line of therapy. And we'll see this in some of the studies that I will show. The next set of drugs are for those who have an ESR1 mutation. Clearly, the SERDs are superior to fulvestrant in this group of patients. You see that the median PFS that you're getting, if you have an ESR1 mutation and you've had a CDK4/6 in the first line, is roughly around 4.5 to 5 months. The other drug is a PROTAC. A PROTAC stands for oral proteolysis targeting chimera. Now, the drug is called vepidagestrant. Now, that is also approved in this subgroup with ESR1 mutated patients. So, you have one for PIK3CA, which is alpelisib. You have one for the PIK3CA AKT-PTEN group, and then you have one for the ESR1 mutation. So, these are the three sets of drugs that you have where you have to test for a biomarker and then decide to use these drugs. Now, remember, I told you that if you have a CDK4/6 in the first line, your median PFS is going to be really dented. And I showed you 11 months with 6% of patients having CDK4/6 for the SOLAR study and 5.5 months for the capivasertib. If you come down here, you see that if your patients have had a CDK4/6 inhibitor in the earlier line, with alpelisib, these are the numbers that you're getting. Look at how it's dropped down from 11 months to around 6 months. So when you're interpreting these numbers, please check whether these patients have actually had a CDK4/6 inhibitor in the first line or not. So no difference in terms of the median numbers between capivasertib or alpelisib. The median numbers are different because of the percentage of patients who had a CDK4/6 inhibitor. The hazard ratios for both of these, which is what you should use to compare studies, are very, very comparable. Now, leaving that aside, all of us hate to use alpelisib. We don't have capivasertib. Elacestrant is available, but that's about it. So, one of the easy fallbacks for all of us is to continue the CDK4/6 inhibitor, or rather, when I say continue, it's continuing the class, not the same drug, and change to fulvestrant from an AI. Now, who should be considered for this? Four trials in that space. Two trials were positive, two trials were negative. Both the palbociclib studies were negative. Now, third had ribociclib. Second important, the majority of patients were on the CDK4/6 inhibitor for more than a year. So a set of patients who had good response and a good run on the CDK4/6 inhibitor. In maintain, it was ribociclib. That was the continuation CDK4/6. In post-monarch, it was abemaciclib. Look at the PFS for the fulvestrant plus the CDK4/6 inhibitor arm. 5.3, 6 months. So roughly around 5.5 months. Remember, alpelisib 5.5 months, capivasertib 5.5 months, post-monarch 6 months, maintain 5.3 months, and the overall response rate is about 20%, not a huge number. So who are those patients who should be chosen for a strategy like this? For me, it's a patient who is on palbociclib in the first line, has had a good run on palbociclib for at least a year, who has a disease burden that is not huge, whose progression is obviously indolent. We don't have any biomarkers at this point in time to choose. Should I choose abema or ribociclib? Both are good enough, but there seems to be a larger body of evidence for abemaciclib compared to ribociclib. So, first line palbo, 1 year on palbo, low disease burden, indolent progression, and a good run on the previous CDK4/6 inhibitor. Abemaciclib is what I would use, but it's absolutely fine to use ribociclib in this setting. So that's that space which we many times fall back upon because you don't want to transition to chemo. At the same time, you don't want to or you don't have access to the other drugs in this space. I'll quickly run you through 3 studies that were read very recently, and then we will conclude. The first is the EMBER-3, which was read last year, but is very relevant to the space that we are discussing because we are discussing the CDK4/6 post space. In the EMBER-3, 63% had a CDK4/6 inhibitor, and the numbers that I'm going to show you now are for the 63%. It's not for the intent to treat. Now look at the primary endpoints of this study. Investigator-associated PFS for immunolesprint versus standard of care endocrine therapy, and that standard of care endocrine therapy is fulvestrant, which many of us would think is inferior by today's standard, but that was what it was. It was positive. But interestingly, for the intent to treat, it was negative. So again, that underlines that important phenomenon that if you're using an oral SERD, it is to be used in patients who have an ESR1 mutation. But imlunestrant plus abema was superior to imlunestrant in all patients. So in the intent to treat, the combination was better than the SERD alone. Now here is this subgroup analysis. Now on the left side is for all patients post CDK4, for all patients. On the right side, it is for the post CDK4/6 patients. no difference in numbers at all, except on the imlunestrant arm, where the number drops to 3.7. Okay, so 9 months is what you get when you use imlunestrant plus abemaciclib in a set of patients who had already had a CDK4/6 inhibitor, and here it was palbo or ribo in this case. All subgroups benefited, including sites of metastasis, ESR1 mutation, or not PIK3CA, whether you had both of these mutations. So it seems to be an all-comer happy combination, need not necessarily be a targeted chase. The other advantage of these combinations seems to be that you may be able to rescue some 15 to 20% of all patients who have a rapid progression on the single agent imlunestrant or the third arm. So there are some advantages to using the combination. Better, you rescue more patients, you have a much better PFS than what you would get with a single agent. And remember, 5.5 months, that's what we discovered or we discussed for capivasertib, alpelisib, and the continuation CDK4/6 studies. Here you're jumping from that 5.5 to 9 months. So that's a decent jump, I would say. So it's a combination worth looking at. The other study is also called as the EVERA study. What did this try to do? This used the SERD plus everolimus versus standard of care endocrine therapy plus everolimus in patients who were progressing on the CDK4/6 inhibitor. Again, interestingly, biomarker selection was not there. Now, remember, we used to push for biomarker testing, and look at how these trials are being conducted today. Very smart. You start with a huge population that is biomarker unselected, but very good. You also power the study to look at a biomarker subset. If you win the whole race, great. If you lose the whole race, you still win a part of it, you still won it. So very, very interesting way of designing studies, but that's the way the future is going to be. Pharma doesn't want to leave anybody out. They want to get everybody in. But I have to say that Eli Lilly for the imlunestrant is not applying for all comers. They're applying only for the ESR1 mutated patients. So in a way, it kind of exemplifies the targeted strategy that all of us want to take now. Again, you see the same kind of numbers here. In the ESR1 mutated patients on the left side and the intent to treat on the right side. In both of these, you get around 9 months as the PFS, very healthy hazard ratios, 0.38 and 0.56. But extremely important is to note that patients with ESR1 mutation were the ones who had benefit irrespective of the PIK3CA mutation, because you would expect that if you had everolimus and if you had a PIK3CA mutation, the benefit would be significant. But unfortunately, while there was benefit, that benefit was very, very modest. So the benefit of the combination was being driven more by the ESR1 mutated patients rather than the PIK3CA mutated patients. So again, exemplifies the case for using a SERD in situations where you have an ESR1 mutation. So it's very important to look at that, and that's part of the biomarker testing that we would love to do today. Again, same story here. You would rescue about 10% of early progressors when you're using a combination compared to if you're using a standard of care endocrine therapy, which is either exemestane or fulvestrant plus everolimus, again, ESR1 mutation. This was read out in 2 conferences. The study 1 part, which is the lower, was read out at ESMO last year, and the study 2 will be discussed again tomorrow in this conference. It was read out at the recently concluded ASCO. What did they try to do here? This is called the Victoria study, and it was victorious, I would say. So they had a triplet versus a doublet. Okay, what was the triplet? It is gedatolisib. Now, what is gedatolisib? It's a pan-PIK3CA inhibitor. Very interestingly, in a post-CDK4/6 space, they had an arm that had palbociclib, okay, which we consider as a very weak CDK4/6 inhibitor, and fulvestrant. So in the PIK3CA space, they compared a triplet with alpelisib and fulvestrant, which is the standard of care in that setting. Now, the lower part has the PIK3CA wild type. Again, same study. You have a set of patients, biomarker non-selected. You have a set of patients, biomarker selected. Throw your hat into both these and then see how you did. Interestingly, in the biomarker unselected patients also, the triplet was better than fulvestrant alone. We'll see the results for the biomarker selected patients. The problem with this is that you have to have an intravenous, because gedatolisib is intravenous, palbociclib is oral, of course, and fulvestrant is intramuscular. So it is not an easy regimen to give patients, but of course the numbers actually look quite decent. Look at the jump here. On the left side, you have 11.1 months for the triplet compared to alpelisib and fulvestrant. Alpelisib and fulvestrant performing exactly what you would expect, that 5.5 months. So it's not underperforming, it's not overperforming, it's exactly giving you the number that you would expect in a PIK3CA mutated patient post CDK4/6 inhibitor. The question is palbociclib necessary? That's on the top right. On the top right, you see that the differences are the same, 11.3 for the triplet, 11.1 for the doublet. So that question can be answered when you come to the response rates in the right lower part of your slide. You see the responses here are nearly 50%, a whopping 50%, I would say. The responses for all the other targeted therapies are roughly around 20-25%. So it's a huge jump in terms of response rate. And that's for the triplet when you add palbociclib. When you take the palbociclib off, you get a 35%, so about 13% better. Very interesting findings, I would say. Very difficult to explain, though, as to how palbociclib is working post-palbociclib, ribociclib, or abemaciclib. The drug seems to be much better tolerated compared to alpelisib for sure, because alpelisib is not an easy drug to use. So when you put all of these together, I'm coming to the end. I'll just take a couple of minutes if I'm exceeding time. Just hang on. Look at this. The combination of all of this, as you move from the left to the right, you see that the best numbers seem to be for the Victoria study. So fulvestrant seems to be the lowest in terms of numbers, and Victoria seems to be the best in terms of numbers. Again, these slides are available for you. You can go through these numbers. Now, the person who's retired hurt here seems to be Serena, because Serena 6 was not approved by the FDA as a strategy for patients within this space for various reasons. Again, we will discuss that in the chat box later if we have time. So Serena 6 is not an approved strategy anymore, so you don't have to keep checking for ESR1 mutations every 2 months. The other question always comes, what is the best control arm for all these studies? Just like all the other situations in oncology today, we are finding a problem with the control arms because we always call these control arms as inferior. So should we have dynamic control arms? We just don't know. That's an open question. That's the last. So that's the sequencing story. As they always say, success brings a lot of complexity, right? And I've got a host. I keep correcting this slide every 6 weeks almost because some new stuff keeps coming all the while. Again, I don't want to take you through this for many reasons, especially want of time. So the question that you have to ask every time that you want to change a treatment is the second slide that I showed you. Is this likely hormone-sensitive disease? What were the previous treatments? Does this patient have rapid progression, high tumor burden? Is there a biomarker or not? If these questions can be answered reasonably well, then you won't find a lot of difficulty in choosing the next line of treatment. Olaparib, talazoparib is something that we didn't discuss for patients with germline BRCA. Third line, of course, you've got the chemotherapy, ADCs, and so on and so forth. So as I always say, disease characteristics, what drugs do you have? What is the data for this? How much do they cost? And of course, desperation and so on and so forth. But ladies and gentlemen, it's very sobering when you go to Monday morning or rather tomorrow morning, because for our practice in this country, I think this is the algorithm that I would recommend. Post CDK4/6, if you have an ESR1 mutant, fulvestrant. If you can get hold of elacestrant, which is now available, that is preferred. PIK3CA, I still think everolimus is a good drug. So fulvestrant plus everolimus or alpelisib. AKT, fulvestrant, everolimus. Germline BRCA, olaparib or talazoparib, wild type fulvestrant plus a CDK4/6. As I said, Abima is what I would use. Fulvestrant plus everolimus is also a choice for this set of patients. But if you think you want the perfect answer to the sequencing story, you won't find it. It's like a perfect boyfriend. Does not drink, does not smoke, does not cheat, and does not exist. So don't look for that yes, no binary answer. You have to put all of this on the table, discuss, and then take a decision on what you want to do. I will stop here. Sorry if I have
Thank you, Dr. Sandil.
Yes.
One can ask him questions on the chat.
Yes.
We are 10 minutes beyond time, so I'll call in Dr. Rajiv, and he will take the panel on triple negative breast cancer. And this is the most practical panel, I think. So what we can do is the addition of immune therapy, immune checkpoint, neoadjuvant 522 worth it. So please, Dr. Rajiv, I'll call the panelists, Dr. Bharat Vaswani from Hyderabad, Ghanshyam Bhai, he's on the screen from Bhubaneswar. I see Prasad. Thank you, Prasad, from Bangalore. He has switched his place of practice in Bangalore itself. And we have our army man, Dr. Brigadier P. Suresh from Delhi. So, Rajiv, can you share your slides and you have half an hour. We'll close at 9:40.
Thank you, Doctor. So can you please ask to share the slides from your
Someone
end, please?
please share the slides of Rajiv.
So good evening, all.
Please.
As Sahu told, let's discuss some practical issues in operable TNBC. Next slide, please. So what we are going to discuss two things. Is it worth adding pembrolizumab in a very early disease, and whether we have any alternate schedule or de-escalate. So straight away coming to the common scenario in our clinic, you have a reasonably young lady diagnosed with CT2N0 disease. I would ask Prasad, is NACT the standard practice? You follow the NCCN guidelines of T1C onwards. How do you go about in your practice?
Yeah, I would give NACT for this patient.
Yeah, and the second question also you can take that, the
chemotherapy backbone in 46-year-old will be AC and paclitaxel.
So dose dense?
Yeah.
Yes. And, by adding the pembrolizumab, do your chemotherapy backbone change, or is it always the same?
It doesn't change.
3 weekly paclitaxel.
So you have the, Bharat, you have something to
Sir,
add?
3 weekly pacli-carbo. If I'm giving a single agent pacli, then I give 2 weekly. Once I add a carboplatin, then I give a 3 weekly along with the immuno whenever it is.
So you try to call them once in 3 weeks so that,
AC is every 15 days, pacli-carbo is every 21 days.
Sure. Now, another question is, Dr. Ghanshyam, do you order BRCA at diagnosis? Do you wait for it? What is your practice?
So I do advise BRCA, but I won't wait for the BRCA report. But because all TNBCs, or in fact all younger patients of breast cancer will have at least a germline BRCA.
So in the current scenario, does all our patients receive platinum, or you select out patients because of the non-availability? Any change in practice in the last few months?
So platinum shortage is there, but still we are managing. So we are not a huge centers, but definitely after the TMH, Dr. Sudhir Gupta's paper. So I think elderly patients we are avoiding platinum. So beyond 50, beyond 55 patients. So where we see lots of hematological toxicity, and the whole protocols gets a haywire. So the pembro dosing, the chemotherapy dosing. So I think omitting platinum in those patients, elderly patients or multiple comorbidities, is a good way. For all younger patients, so we are in fact advising platinum.
So let's say if it's a 58, 60-year-old lady and you're adding pembrolizumab, would you add platinum or?
So I do add, but if I see a hint of hematological toxicity, then I will stop. At least I have in my backyard, so I have a paper which suggests that it was not beneficial and hematological toxicity was significant. And we do see hematological toxicities, anthracyclines and taxanes, including a platinum. Sir, we try to give it in a weekly form by adding, so that modifies or reduces the toxicity.
So Bharat, most of your patients do receive carboplatin.
Yes, sir. Unless there is a contraindication or what I say
elderly, maybe more than 65. What we do is AC4 followed by, although not like a standard keynote trial, weekly paclitaxel for 12 weeks, along with 3 weekly pembro. Although was not the trial was it was all about, but sir, at the end of the day, adding platin adds up to our survival. We have a good analysis now, meta-analysis, which suggests that it is always good to add a platin in your chemotherapy backbones.
Look, Suresh, does this patient will receive pembrolizumab definitely in your practice?
Yes, so as an institutional protocol, we are giving pembrolizumab, and since there are no cost issues here, so we are giving pembrolizumab plus paclitaxel plus AC for all our TNBC patients. But I would like to add that maybe the toxicity is not due to pembrolizumab, but the 12 weeks of weekly paclitaxel does result in delays of many of the times because of toxicity.
Also, just to continue with that, Dr. Suresh, so because cost issue is not there, so all your patients will receive 1 year of pembrolizumab. Let's say this patient will receive 1 year of pembrolizumab.
Yes, yeah, we are continuing pembrolizumab if the as an adjuvant, as a perioperative kind of thing or adjuvant kind of thing to complete the course of pembrolizumab.
So once you commit to pembrolizumab, you're completing 1 year. Prasad, any thoughts on that?
Yeah, I mean, if you are committed to starting with the neoadjuvant, mostly I give for 1 year, and also this patient support program, which is there now, almost makes it not a big discussion point actually.
Sure. Okay. Next slide, please. So this is the subset analysis which showed that the benefit in CT2 and 0, you will have the significant benefit. So as most of the panelists suggested, there will be discussion on pembrolizumab even in early stage disease onwards. So is there any subset where you would consider straight surgery in this setting, Prasad? So if it comes to you first, yeah. No, early breast cancer, TNBC, which subset where you would actually definitely consider surgery?
So we hardly see these T1 lesions actually. So anything which is T2, clinical T2, I will give neoadjuvant therapy. That
So
is the
T2
practice.
and above will be neoadjuvant. Sure. Bharat?
Yes, sir, agree with it. All T2, up more than 2 centimeter neoadjuvant for all in a TNBC. And one more thing with Pembro. In fact, if you see the ESMO guideline, anything more than 1 centimeter, you have to give a neoadjuvant, 1 to 2 without immuno, and from 2 centimeter onwards with immunotherapy.
Sure, that will come to later. Next slide, please. So I think the Dr. Sahu wanted us to discuss and deep dive into 2 questions. So we will look into more details, as most of the panelists have said that after CT2 onwards, we are going to consider pembrolizumab committed for 1 year. Is it all worth it? We will look at the final analysis of keynote study. And then the next question comes is majority of the patients, if you take India as a whole, may not be able to bear the cost of this 1 year of pembrolizumab. So can we do it leaner? With the Indian data planet trial, we look into whether we can switch the schedules, shorten the duration, take out the adjuvant part, or use a low dose or alternative drug itself without losing efficacy. So I think these are 2 important questions which we will be discussing in the remaining time. Next slide, please. So this was the keynote trial. So Bharat, if you can take it. So this was a well-conducted trial. It was a randomized with 2:1
all good things in a trial, all the active agents, AC, carbo, pacli, along with the drug which we were testing, 4 plus and 8 pre, then a surgery and another 9. So completing 17 doses in over a duration of 1 year. A very well conducted study, quite a big number, 1,174. So carries a lot of weight. Rightly T2 onwards, which we commonly see. If I have to remember, 50-50 node positive, node negative. T2 were also predominantly very high numbers of patients. So all in all, a well conducted randomized study. So probably carrying a lot of meaning, or what we say, we base our practice on this pivotal study.
So the primary endpoint was PCR. So would you have liked, after PCR, if they have randomized to no Pembro versus continuation of Pembro, would that have been a better study design, or you're happy with this? Yeah.
Earlier part, probably this would have been an ideal trial, and what Sao sir also mentioned, that whether you really require an additional, but sir, at that time, the immunotherapy drug, whether it should have been used or not, that was a prime thing. Now,
Yeah.
what we know from the study is that IO are here to stay and has to be a important part, or a most important part of the treatment. Probably in the next step, we will see, or there are some trials which are being conducted, as you will discuss maybe later.
Yeah.
We might know an exact answer whether Pembro really helps in those with a PET-CR. As far
Correct.
as now, I use it in all my patients.
Dr.
Yes.
Rajiv, if I can add, so
Yeah.
I noticed that this question was raised as a correspondence in NEJM, and the
Yes.
authors have replied that in the patients who could not take pembrolizumab in the adjuvant setting who had PCR, so
Yes.
there was a 5% difference in EFS. 8.9 versus 13.4% was the recurrence rate in patients who had a PCR. So there was approximately 4 to 5% difference versus a 10% difference in patients who did not have a PCR. So the authors had given a reply to that correspondence.
I think that's interesting. That's a little bit complex, because we take the primary endpoint as PCR, and we suggest that PCR has better EFS, but then even in non-PCR it works. So it's slightly
Sir,
more
I want to
complex.
add one more. What sir
Yeah.
said rightly, at the end of this 93 months, when those patients who had a PET-CR is around 94.5 versus 89.9. So definitely there is some benefit, 4.5%, although the most quantum of benefit is those with non-PET-CR. But 4.5 absolute percent at the end of this trial is also something that we have to look into.
Good enough. Next slide, please. So the PCR result, as Bharat was mentioning, is quite impressive, and it was consistent across subgroup. So well conducted trial, and even nodal status, tumor size, and the benefit was not confined to PDL1 positive disease. But then node positive subgroup had the largest impact, which was quite obvious. Next slide, please. And when we have the mature result, Dr. Gansham, how do you see this? What will be the discussion point with the patient? Because you have significant overall survival gain at 7 years. Your hazard ratio is 0.6. Does this make it forceful to discuss all our patients, irrespective of the financial, at least to have a discussion that this is an agent which can make a difference?
Yeah, so we never thought that even in a TNBC, so which are high risk basically, which were taken into keynote 522, and they will see the 8th anniversary. So that makes a big impact in the practice. So that means IO is needed in a neoadjuvant setting in triple negative. Now the discussion can be the full dose or so we can omit in an adjuvant setting or not, but so definitely that making a big impact in the lives of a TNBC, which is supposed to be an aggressive tumor. And if you take the high risk disease, which was taken into in the keynote 522.
Yeah. Next slide, please. So I think if you look at the treatment strategy, the keynote is the standard way to go. You give chemo plus IO neoadjuvant followed by IO. But then if you look at, we can also look at chemo followed by IO adjuvant, or IO plus chemo adjuvant. So these are few different strategies, and we'll see how it has fared. Next slide, please. So this we have discussed. Neoadjuvant is the standard, and immunotherapy is there to stay. And initial discussion is going to be happening in all our patients, because it has tested time, and 7-year overall survival has been significant with the addition of pembrolizumab. Next slide, please. So the question again, melanoma studies showed us, and most of the other studies, where it works well in neoadjuvant, but it hardly works in adjuvant. So Prasad, you have any answer for that? Next slide, please.
No, I think more and more data of wherever we give neoadjuvant immuno, I think we are coming to this conclusion that the best option is to give when the tumor is there. And the most practiced neoadjuvant plan of treatment is mostly in breast cancer and probably in lung. So that is where we have seen that the neoadjuvant is the best when we want to give immunotherapy. I think I am convinced about that. And
So
when
that
you
is
talk
where I
about the
think most of
significance
the
of this
time,
trial, the
yeah.
long-term data, I think so many other trials have failed in this scenario, right? So if as Dr. Bishwas said, nothing actually improved the outcome in triple negative breast cancer other than the platinum addition. I think this is a significant study, and the best way to give it upfront is neoadjuvant only.
I think very lucidly put, and you have also told that if she walks into a clinic, CT2N0 will get 1 year of Pembro. But by mistake, she walked into the other side of the door and went to the surgeon. And, we have the straight surgery and PT2N0. How do
We
you
can't give
approach
it,
that?
right.
So, that's a little bit complex, right? That's a huge benefit in immuno, and we feel that adjuvant immuno also works. So what is your explanation for that? Is it only after neoadjuvant IO does the adjuvant work? Why is that such a big impact?
So we can only say that there is no data, right? And
Sure.
so that is the only answer we can give. And we sometimes even see patients with stage 3 who have come after surgery. These are all things which happen in practical life, and we may want to
Yes.
consider immunotherapy, but there is no data to give.
Absolutely. Next slide. So I think if you have such a setting, this is the ATSO data, which is the Alexandran impassion. Unfortunately, as Prasad rightly mentioned, it is negative. Next slide. So the use of immunotherapy did not add in the adjuvant setting. So whatever temptation we have, we simply don't have data to use it in the adjuvant setting, and we really cannot understand when we say that after neoadjuvant still the adjuvant makes a difference. So any of the panelists has an explanation for that, like is that the milieu being changed when the tumor is there using neoadjuvant IO, and then still the adjuvant works, but a pure adjuvant doesn't work.
That was the concept in the head and neck cancers, no? So so I think so the milieu gets changed. So we are making these are tumors which are already immunogenic, and so probably with the tumor in place, so probably we are making more immunogenic tumor, and that's why these patients probably will respond in an adjuvant setting if they are used in a perioperative setting.
Even a wrong drug.
Sure. Next slide, please. So if you have, with PCR or without PCR, I think most of you have answered that you would continue that, mainly because you mentioned the cost issue. So any of the panelists are worried about the toxicity, like, you have a PCR, we know that the benefit is little bit. So will there be a discussion on continuing adjuvant, or if there is no toxicity, we would like to complete 6 days?
If there are grade 3 to grade 5 toxicity, obviously if somebody has achieved the PCR, we are going to stop that. So if at all PCR was not achieved, then again a grade 4 or grade 5. So again, so probably we'll discontinue the treatment, no? But definitely in a PCR, so any amount of toxicity, significant toxicity won't be accepted.
Sir, I have one point to add. If you go through the toxicity profile in Keynote, there was 7% discontinuation. Overall, as a drug, immunotherapy, 7% drug discontinuation. But saying this, when you go through the data, the commonest toxicity was hypothyroidism,
yes.
15%, hyperthyroidism, and skin toxicity. And when you look into that bad toxicities like pulmonary, it was less than 3%. So my take on it is we don't stop IOs when it is endocrine problem like hypo or hyperthyroidism. So although these were lot of toxicities, but I don't think so that grade 3, grade 5 toxicity that we worry about like pneumonitis, colitis or hepatitis, that was less than 3%. And when you look into grade 3 to 5, it was less than 1% or 1.5%.
So many of these hypothyroidism would have been contributed by post-op radiation also, no?
So I think
Next
I
slide.
also agree that the toxicity is less, but since we have been giving for a lot of patients, we have seen
Yes.
interstitial lung disease kind of or a pneumonitis kind of pattern in a few patients. It does
Yeah,
occur,
I
but
think
That
very,
interstitial
very
lung
less,
disease can
very less, very
come
less.
from vaccines also, no? So
That is also there.
Radiation.
Yes.
toxins. So
Yeah,
that
it could be because of toxins also. We cannot prove or disprove either way. Correct.
Sure. I think that's very rightly told, Dr. Suresh. When you have a PCR and then you continue and you get into a toxicity, that is when you will think twice whether whether we made the right decision. Next slide, please. So if you look at post neoadjuvant IO, also if there is keynote 522, that is where the adjuvant works. Next slide. So this we have discussed, where it looks like even the cohort of patients whom after the first cohort has been looked into, then if you look at the interim analysis, then you can see that it does work. Next slide. So after as I told, this same EFS improvement without a PCR increase, there is some effect during the adjuvant period. We really don't know what is the answer for that, and effect in the newer adjuvant period, and other than the PCR increase is also there. So that's what our panelist has been trying to tell, that it is better to continue for 1 year if it is feasible, even though after PCR the benefit is very less. Next slide. So if you look at many of the subsite, we have got adjuvant data also, but here is in breast cancer, we really have negative data for adjuvant setting. So as Prasad told, even if it is PT3 in high nodal disease also, though we know that they are going to be very high risk for relapse, we don't have simply data to add immunotherapy. Next slide. Is there any strategy of using only if you have used chemotherapy and if you don't have a PCR, Prasad, would you be tempted to use adjuvant IO? That is a tailored strategy. And the second question, I think you have answered. If you have a PCR, you are going to continue.
Yeah. So neoadjuvant chemotherapy, no PCR, regardless of PCR, I am giving. And as Sahu has discussed in the chat also.
No. Here we have not used chemo. I mean, IO in the
No, I will
neoadjuvant
not
setting.
give. I will not escalate to IO just because there is no PCR. Maybe in that situation, our usual protocol of adding capecitabine.
Createx or olaparib. Yeah, I think
Dr.
that's
Rajiv, I
more
have a question. So because the trial had used conventional paclitaxel, but how many of us are using nab-paclitaxel?
Yeah, the panelists, can you tell how many are using nab-pacli? Are you interchanging? Because you told you can use dose dense, some are using weekly. So nab-pacli are we using?
Conventional, I use conventional paclitaxel.
I use conventional, sir.
Only when the patient develops a reaction and is unable to tolerate
yes.
paclitaxel, we have paclitaxel.
That is true.
Sure. Next slide, please.
And second is that, so in a neoadjuvant setting, we are not looking at a PDL1 because more than 80% are high PDL1. But if you look at the triple negative metastatic disease, so only PDL1 high more than 10, CPS more than 10 will have only 30 to 40%. So the biology and the biomarkers gets changing.
That's true. Yes.
But even in less than one, there is the difference was quite good enough when you look into that forest plot. But the numbers were less because 80% were PDL1, at least 1% positive in that.
I think this question Dr. Prasad has answered, but there was a trial which looked at after neoadjuvant chemo, whether we can use adjuvant IO in case if there is no PCR. That's a brave trial. Next slide, please. So this study was also negative, but it was a little bit underpowered with a modest hazard ratio. However, there is some trend towards overall survival, but then the priority should be neoadjuvant IO plus chemo. If you are committed to use it neoadjuvant, and we really don't have data to use it even if not in PCR after neoadjuvant chemo. Next slide, please.
Yeah, I think Rajiv, this trial was 2 years back ASCO, and this had that OS advantage somehow.
Absolutely,
Although the
yes.
primary endpoint was negative. So that
So,
is the
Sahu,
irony
in
of
that situation, that patient comes to you, will you add 1 year of?
No, I think the statistically not powered for it, and avelumab is too costly on price wise also to justify.
Okay.
So two questions, Rajiv, because we move forward.
Yes.
The panel, or you can put it because that's very relevant. We had the AIMS data read out by Batul,
Yeah,
which had
I'm
50
coming to it.
mg.
I think we'll
Are you
go
coming
straight
to
to
that?
that. Yeah.
And the
Yeah.
toripalimab. So where can we substitute for patients because the cost really decreases substantially by 30 to 40%,
Yes.
maybe by half.
So I'll just come to that. Can we
Yeah,
can we forward the
you have
slides,
5 minutes.
please?
You have 4 minutes more.
Yeah, I don't have control over the slides. So yeah, next slide, please. Next slide. I think we have discussed this. So I think the question one we have sort of discussed. The most of us we have decided that based on the mature data of Keynote, we are going to add pembrolizumab. But then there is some caution about continuing after PCR if there is toxicity concern. Cost, they, as rightly told, may not be very practical in the Indian setting. Next slide, please. So I think this comes to more important question is it is out of reach. There was some data which says that less than 3% finally who required immune checkpoint inhibitor took it in any setting in India. So that's some reality for us. So the question is whether we are going to de-escalate, and that's where Atul's paper comes in. Next slide. So you're going to reduce the dose, you're going to increase the schedule, or you're going to change the agent altogether? That's Sahu's question. Next slide. So this was the Planet trial. This is pembrolizumab dose given 50 mg every 6 weeks for 3 cycles, and compared to the pembrolizumab dose, which was 200 mg every 3 weeks for 17 cycle. So this was presented by AIMS Dr. Atul in ESMO 2025. Next slide. So you had comparative PCR data. This is what the best we can do. So Prasad, your comments on that? Do you get patients whom we need to discuss this?
No, I have not given this actually, but the data is definitely interesting. This 50 milligram thing also is a problem outside of
Yes.
a center like AIMS or Tata actually to give, and definitely PAT-CR. If you look at that as an objective, this is as good as. So if a patient we want to give neoadjuvant immunotherapy and not able to give the
full dose, yeah.
full dose, we can consider. But I would the problem with this is that this is already presented and done. So what are we going to do with this data if you don't take this ahead and find out it leaves so many questions unanswered actually.
Yeah. Sahu, because of the volume at your center, I think you will be able to do split dose and use. So have you started using Planet trial in your?
Yeah, my center. So I think the more practical point is what Prasad spoke.
Yes.
First thing is that the 50 mg they're dividing, but
Yes.
point here is the PATCR was equal. Does the PATCR go into the event-free survival? And Atul, I have asked this, and he told that the trial, the money and everything involved, that he could do this, and he has proven that first point actually, and which is a great welcome actually. But my very specific question is, if you have the slides on the toripalimab, because the data is very mature, although there could be criticism. Do you have the slides on that, Rajiv, the tori data?
Toripalimab, no, I have not added.
Okay, so
there is a
an
phase 2
answer.
on neo-tennis, but that had only 70 patients. It's a phase 2 study that have only reached a pathological CR in the breast and total pathological CR.
No, the Neo-Tori has a data which is there,
Yes.
which is the phase 3 data set. So, where do people feel that a patient who cannot afford those 10, 12 lakhs and can go for 6 lakhs? Would be people, all of us be comfortable switching at this point to the toripalimab? And or do you want to wait further for more data set or maturity?
So are you sure it's a phase 3? So neo-tennis is a phase 2, 70 patients only, and pathological CR and only total pathological CR is there.
No. Bharat?
Pardon, sir. Sorry, sir.
Toripalimab.
Sir, I would use it, sir, because that data looks impressive also. And in a resource country like India, I think so. This is an option that we need to discuss. Sir, unfortunately, because not an American drug, so a lot of controversy, but toripalimab data is equally impressive. And I think we have started discussing, at least at my center. low dose I have not discussed, but toripalimab I have started discussing, and probably this is a good drug only, sir. We have a data in lot of indication now. These drugs. So I definitely will use this in our discussions whenever I see a TNBC, and probably in future, if I think all of us will be discussing it as more and more data will be coming.
Ghanshyam is right. I understand it's a phase 2 data set. NeoTorch is a phase 2 data set that I'm pretty clear about it. So I agree to that. The best evidence is for Keynote 522. If they cannot, probably Tul's paper also comes in, and also the NeoTorch can be discussed. But I think at this point, the most mature data is for 522. So
what we can do is like putting in 100 milligram 6 weekly, so that because it comes as a 100 milligram vial rather than so for private practitioners like us. So
Agreed.
No, I think that also is the problem. No, you get 1 + 1 also. So
anyway, 3 doses have to be purchased.
Right. So somehow it is not.
So
50 also we have to purchase.
Prashant, so there was no adjuvant phase, no? There was no adjuvant phase. So you required only purchasing of 2 vials only, no? So with 4 vials, the game is over.
Yeah, I agree.
And I think one more point of Keynote 522, which I would like to emphasize, in the latest 75-month follow-up, which was published recently, the pathological response rate had decreased from 13.6 to 7.4%. So the initial 13.6 was in the 602 patient, initial 602 patient, this thing. But when they added all the 100 patients or whatever, it had decreased to 7.4, and the authors do not have an explanation exactly as to why this has decreased. This is important in the context of our new trials, which we are discussing of toripalimab as well as our low-dose pembrolizumab. So a longer-term, follow-up is definitely required. And if you look at the overall survival analysis for 2 years almost, the curves are touching each other or they are crossing each other in the Keynote 522. And they have used a restrictive mean survival time analysis, which is about 2 months improvement at 5 years. So the overall survival benefit is also not that great in the Keynote 522. These are also points which we may have to think about.
Survival advantage is quite good. I think 7.5% absolute gain in survival is unheard of.
Actually, Bharat, what Suresh makes, I didn't want to make it repetitive. I've been the most important proponent for that RMST thing, and that has been in the first NEGM publication, and Suresh brought it very relevant. Last minute, I'll just put in. People should go and read it. Because in the first 2 years, if you look at it, the first 18 months to 24 months, as Suresh told, the OS curves just crisscross each other at least 3 to 4 times. And then the separation happens. And if you look at the Kaplan-Meier, the P values is more for the uniformity. And here it is a non-uniform Kaplan-Meier. So then when they use the RMST curve, the benefit that was there at 5 years for addition of immunotherapy at 5th year as per the NEGM is only 2 months. So point here is that is probably statistically the more better way of looking at the difference, because both the curves are not uniform actually. So that 0.63 hazards or 0.7 hazards, is it applicable? So that is a non-uniform hazards actually. So that is what Suresh mentioned
it's not a proportionate hazard. That is where the hazard.
Exactly.
It's not
I think on that note, I conclude.
So last question, because I have 1 minute.
Yeah.
Does that bother the panelist about what Suresh brought in, that statistically speaking, a non-proportional hazards, the RMST curves look only at difference of 2 months of 5 years. So does it bother? And Suresh, to you specifically, because you are in the armed force where taxpayer money goes in, does it come into discussion of drug approval? Very hard question. You may not answer directly.
Yes, I think it is an important point, and we personally are thinking of using low dose pembrolizumab due to this point. I mean, maybe mg per kg or the what do you call the
2 milligram per kg is what you're looking at.
So that at least we decrease the cost when we know that the final benefits are not that much. So maybe at least we can decrease the cost by using an mg per kg or fixed dose regimen as per the AIMS trial.
Thank
or
you.
as Satish mentioned in the comment, as generic pembrolizumab will come.
We have to wait 1.5 years. So and nivolumab generic has not decreased the cost by much. So I don't expect that to also decrease till we go for an ultra low dose Pembro. Then the 50 mg will come in. We'll have generic 50 mg vials. That will be the only advantage probably. And that's where Atul Batra's trial will pick up. So thank you, and Rajiv and all the panelists, thank you. Thank you, Suresh, specifically for bringing in something which I thought the panel would discuss, and you brought it at the last, the RMST, the non-proportional hazards. And the students who are there should go back, read the first NEJM article on Keynote 522, read into that paragraph of the RMST, which is very well written actually, and then take their call on it. So with that, I will bring this day one discussion to halt. And thanks everyone who has joined today, and they have stayed on actually for the whole 2 hours. Tomorrow we'll start dot at 7:30 to discuss the advanced breast cancer scenario. And we have saved the best for the last. The top 3 picks of ESMO Breast 2026 and ASCO 2026 will be done by Dr. Atul Batra, the author of the Planet Tile, who read out Planet actually in the ESMO last year. So please do join, and let's see how the day 2 goes. But again, thank you for day one, for all those who joined, all the faculties, and definitely the back team support. So I would like to end the day one today, expecting that we will have the audience back on day 2 for a good discussion on day 2 on the metastatic breast cancer. Thank you.
Thank you.
Thank you.
Thank you. Thank you everyone for joining deep dive, and meet you tomorrow. Good night everyone at the same time. Good night everyone.